We are continuing discussion of the general pathology of infection diseases, and today we will be talking about Echinococcus, Actinomycosis, trichinosis as an examples of granulomatous diseases. Echinococcus in humans occurs as a result of infection by the larval stages of tiny cestodes of the genus Echinococcus. 6 species have been recognized, but 4 are of public health concern. Echinococcus granulosus, which causes cystic echinococcus, Echinococcus multiculars, which causes alveolar echinococcus, and Echinococcus vogeli and Echinococcus oligarthus, which cause polycystic echinococcus. 2 new species have recently been identified: Echinococcus shikucus in small mammals from the Tibetan Plateau and Echinococcus felidis in African lions, but their zoonotic transmission potential is unknown. Several studies have shown that these diseases are an increasing public health concern and that they can be regarded as emerging or re-emerging diseases. Today we will discuss aspects of the biology, life cycle, etiology, distribution, and transmission of the Echinococcus organisms, and the epidemiology, clinical features, treatment, and effect of improved diagnosis of the diseases they cause. New sensitive and specific diagnostic methods of echinococcus have been developed in the last 10 years. Despite some progress in the control of echinococcus, this zoonosis continues to be a major public health problem in several countries, and in several others it constitutes an emerging and re-emerging disease. Echinococcus granulosus is a cestode whose life cycle involves dogs and other canids as definitive hosts for the intestinal tapeworm shown on the picture, as well as domestic and wild ungulates as intermediate hosts for the tissue-invading metacestode larval stage. The metacestode echinococcal cyst is a fluid-filled spherical unilocular cyst that consists of an inner germinal layer of cells supported by a characteristic acidophilic staining a cellular laminated membrane of variable thickness. Each cyst is surrounded by a host-produced layer of granulomatous adventitial reaction. Echinococcus eggs contain an embryo that is called an oncosphere or hexanth. The name of this embryo stems from the fact that these embryos have 6 hooklets. The eggs are passed through the feces of the definitive host, and it is the ingestion of these eggs that lead to infection in the intermediate host. From the embryo released from an egg develops a hydatid cyst, which grows to about 5 to 10 centimeters within the first year and is able to survive within organs for years. Cysts sometimes grow to be so large that by the end of several years or even decades they can contain several liters of fluid. Once a cyst has reached a diameter of 1 centimeter, its wall differentiates into a thick outer, non-cellular membrane which covers the thin germinal epithelium. From this epithelium, cells begin to grow within the cyst. These cells then become vacuolated and are known as brood capsules, which are the parts of the parasite from which protocolysis bud. Often daughter cysts also form within cysts, as shown on the picture on the slide. Echinococcus adult worms, shown on the picture, develop from protocolysis and are typically 6 mm or less in length and have a scolex, neck, and typical 3 proglottids, one of which is immature, another which is mature, and the third of which is gravid or containing eggs. The scolex of the adult worm contains 4 suckers and a rostolum that has about 25 to 50 hooks. Geographically distinct strains of Echinococcus granulosus exist with different host affinities. Molecular studies using mitochondrial DNA sequences shown on the picture have identified 10 distinct genetic types within Echinococcus granulosus. These include 2 sheep strains, 2 bovid strains, a host strain, a camelid strain, a pig strain, and a cervid strain. A 9th genotype, G9, has been described in swine in Poland and a 10th strain in reindeer in Eurasia. The sheep strain is the most cosmopolitan form and is that most commonly associated with human infections. The other strains appear to be genetically distinct, suggesting that the taxon Echinococcus granulosus is paraphyletic and may require taxonomic revision. The cervid or northern sylvatic genotype is maintained in cycles involving wolves and dogs and moose and reindeer in North America and Eurasia. Human infection with this strain is characterized by predominantly pulmonary localization, slower and more benign growth, and less frequent occurrence of clinical complications than reported for other forms. The presence of distinct strains of Echinococcus granulosus has important implications for public health. The shortened maturation time of the adult form of the parasite in the intestine of dogs suggests that the interval period for administering anti-parasite drugs to infected dogs will have to be shortened in those areas where the G2, G5, and G6 strains occur. Certain human activities facilitate transmission of the sheep strain and consequently raise the risk that humans will become infected. As shown in the picture, in endemic areas, dogs often have ready access to viscera from slaughtered livestock. Dogs infected with Echinococcus tapeworms pass sex in their feces, and humans become infected through fecal oral contact, particularly in the course of playful and intimate contact between children and dogs. Eggs adhere to hairs around an infected dog's anus and also are found on the muzzle and paws. Indirect transfer of eggs, either through contaminated water and uncooked food or through the intermediary of flies and other arthropods, can also result in infection of humans. The greatest prevalence of cystic echinococcosis in human and animal hosts is found in countries of the temperature zones shown on the picture, including South America, the entire Mediterranean, southern and central parts of the former Soviet Union, Central Asia, China, Australia, and parts of Africa. In the USA, most infections are diagnosed in immigrants from countries in which echinococcosis disease is highly endemic. Sporadic autochthonous transmission is currently recognized in Alaska, California, Utah, Arizona, and New Mexico. Echinococcus granulosus infection has reemerged in certain areas where it was once believed to be controlled. In Bulgaria, the incidence of cystic echinococcosis in children increased from 0.7 to 5.4 per 100,000 population between the 1970s and the mid-90s following the collapse of control efforts. In Wales, the prevalence of infected dogs has more than doubled between 1993 and 2002, following policy changes favoring health education over weekly dosing of dogs with praziquantel. After ingestion, Echinococcus eggs hatch and release embryos in the small intestine. Penetration through the mucosa leads to blood-borne distribution to the liver and other sites where development of cysts begin. Most primary infections in humans consist of a single cyst. However, 20 to 40% of individuals have multiple cysts or multiple organ involvement. The liver is the most common site of the echinococcal cyst of the pastoral strains followed by the lungs. The cyst is seen less frequently in the spleen, kidneys, heart, bone, and central nervous system. Even though infections may be acquired in childhood, most cases of liver and lung cysts become symptomatic and are diagnosed in adult patients because of the slowly growing nature of the echinococcal cyst. Only 10 to 20% of cases are diagnosed in patients younger than 16 years. However, cysts located in the brain or in eye can cause clinical symptoms even when small. Therefore, most cases of intracerebral echinococcosis are diagnosed in children. The clinical manifestations of cystic echinococcosis are variable and are determined by the size, and condition of the cyst. The rates of growth of cysts are variable, ranging from 1 to 5 centimeters in diameter per year. This slowly growing echinococcal cyst often is tolerated well until it causes dysfunction because of its size. The signs and symptoms of hepatic echinococcosis can include hepatic enlargement, right epigastric pain, nausea, and vomiting. If the cyst ruptures, the sudden release of its contents can precipitate allergic reactions ranging from mild to fatal anaphylaxis. On the left picture, you see a hydatid cyst of liver. On the right picture, hydatid cyst laminated membrane. The cyst wall is made up of a laminated membrane shown by the arrow, which is lined by germinal epithelium. In the lungs, ruptured cyst membranes can be evacuated entirely through the bronchi or can be retained to serve as a nidus for bacterial or fungal infection. On the left picture is a chest computed tomography demonstrates a huge cyst in the left lung. On the right picture, a pulmonary tissue with a hydatid cyst composed of a laminated membrane lined by a germinal layer and surrounded by thick fibrous tissue. A daughter cyst is present inside the main cyst. Dissemination of protoscolysis can result in multiple secondary echinococcosis disease. Larval growth in bones is atypical. When it occurs, invasion of marrow cavities and spongiosa is common and causes extensive erosion of the bone. On the left picture, you see a cortical thickening and sclerosis with intervening cystic lucences in the diaphyses, shown by the arrowheads. On the right picture, protoscolysis of Echinococcus granulosus, shown by the black arrows, with a chain of hooklets in the germinal layer. The presence of the cyst-like mass in a person with a history of exposure to sheepdogs in areas where Echinococcus granulosus is endemic supports the diagnosis of cystic echinococcosis. However, echinococcal cysts must be differentiated from benign cysts, cavitary tuberculosis, mycosis, abscesses, and benign or malignant neoplasm. A non-invasive confirmation of the diagnosis can usually be accomplished with the combined use of radiologic imaging and immunodiagnostic techniques. Radiography permits detection of echinococcal cysts in the lungs. In other sites, however, calcification is necessary for radiographic visualization. Computed tomography, magnetic resonance imaging, and ultrasonography are useful for diagnosis of deep-seated lesions in all organs, and also for determination of the extent and condition of the avascular fluid-filled cysts. On the pictures is a chest X-ray shown on the left and computed tomography that reveal a giant cystic lesion occupying the right hemithorax, shown by the arrow. Abdominal ultrasonography has emerged as the most widely used imaging technique for echinococcosis because of its widespread availability and usefulness for defining numbers, side dimensions, and vitality of cysts. Portable ultrasonography machines have been applied for field surveys with excellent results. On the picture, you see multiple anechoic areas with central hyperechoic area appearing in left lobe of the liver. Hydatid cysts detected by B-mode ultrasound. Antibody assays are useful to confirm presumptive radiologic diagnosis, although some patients with cystic echinococcus do not demonstrate a detectable immune response. Specific confirmation of reactivity can be obtained by demonstration of specific echinococcal antigens by immunoblot assays. Eosinophilia is present in 25% of infected persons. In seronegative individuals, a presumptive diagnosis can be confirmed by the demonstration of protoscolysis or hydatid membranes in the liquid obtained by percutaneous aspiration of the cyst. On the picture you see an Echinococcus granulosus derived immune modulators. Parasite-derived molecules function at several levels on crucial immune regulatory cells. Until the 90s, surgery was the only option for treatment of echinococcal cysts. However, chemotherapy with benzimidazole compounds and more recently treatment with cyst puncture, aspiration, injection of chemicals, and reaspiration have been introduced and increasingly have supplemented or even replaced surgery as the preferred treatment. The benefits and limitations of current treatment options have been reviewed by the World Health Organization Informal Working Group on Echinococcus. Surgical removal of intact hydatid cysts, when possible, remains the treatment with the best potential to remove cysts and lead immediately to complete cure. The aim of surgery is total removal of the cysts with avoidance of the adverse consequences of spilling the contents. Operative mortality varies from 0.5 to 4%, but rises with repeated interventions and when surgery is performed in inadequate facilities. Documentation of experience with chemotherapy using benzimidazole compounds is now extensive, and this medical approach can be recommended for many patients. Approximately a third of patients treated with benzimidazole drugs have been cured, and even higher proportions, 30 to 50%, have demonstrated significant regression of cyst size and elevation of symptoms. However, 20 to 40% of cases do not respond favorably. In general, small, isolated cysts surrounded by minimal adventitial reaction respond best, whereas complicated cysts with multiple compartments or daughter cysts with thick or calcified surrounding adventitial reactions are relatively refractory to treatment. Percutaneous aspiration, injection, and respiration, abbreviated as PAIR, is shown on the picture. A third option for the treatment of hydatid cysts in the liver and some other locations consists of percutaneous puncture using sonographic guidance, aspiration of substantial amounts of the liquid contents, injection of the protoscolicidal agent for at least 15 minutes, respiration, and here comes the abbreviation PAIRS: puncture, aspiration, injection, and respiration. PAIR is indicated for patients who cannot undergo surgery and for those who refuse surgery who have single or multiple cysts in the liver, abdominal cavities, spleen, kidney, and bones. PAIR is contraindicated for inaccessible or superficially located liver cysts and for inactive or calcified cystic lesions. The earliest successful control program was that in Ireland, initiated nearly 130 years ago when cystic hydatid disease was recognized as affecting approximately 1 in every 6 Icelanders. An extremely effective health education campaign sensitized the entire population to the disease, and subsequent measures virtually eliminated home slaughter of sheep, resulting in the gradual elimination of transmission. By the 1950s, echinococcus was considered eradicated from Iceland. Programs initiated in New Zealand and in Tasmania were primarily based upon education of rural populations and motivating them to change their practices. Strict control and prohibition of farm slaughter were key features in those programs. The initially voluntary nature of the programs was reinforced by legislative acts and strengthened efforts at enforcement as the programs progressed. This policy proved highly successful. The number of infected dogs fell steadily throughout the campaigns. Decline in canine infection preceded drops in prevalence of infection in sheep and young cattle and reduced number of cases in humans diagnosed annually. In New Zealand, the first year when no dogs were found infected was 1985, and hydatid cysts in sheep are now rare. No new human cases of hydatid disease have been reported in children or adults under 19 years old since 1977. Cystic echinococcus has been declared provisionally eradicated in both Tasmania and New Zealand. A program in Cyprus benefited from very aggressive stray dog elimination and strict control of working dogs and those kept as pets. All used diagnostic purging of dogs with auriculine as a surveillance technique for monitoring the effectiveness of the program and identifying problem farms. Tasmania quarantined infected dogs and infected sheep flocks. Regional programs in Argentina, Chile, and Uruguay benefited from the use of the highly effective echinococcidial drug praziquantel. Surveillance data from all these programs documented the reduction of prevalence in dogs, animal intermediate hosts, and humans. A promising advance has been the development of a recombinant vaccine, which seems to confer 96 to 98% protection against challenge infection. Recent trials in Australia and Argentina using this vaccine have reported that 86% of vaccinated sheep were completely free of viable hydatid cysts when examined 1 year after immunization. Alveolar echinococcus results from infection by the metacystode larval form of Echinococcus multilocularis. In rodents, the natural intermediate host, the larval mass, proliferates rapidly by exogenous budding of germinative tissue and produces an alveolar-like pattern of microvesicles filled with protoscaleces. In humans, the larval mass resembles a malignancy in appearance and behavior because it proliferates indefinitely by exogenous budding and invades the surrounding tissues. Protoscaleces are rarely observed in infections of humans. The life cycle of Echinococcus multilocularis involves foxes and their rodent prey in ecosystem generally separate from humans. However, there is ecologic overlap to humans because fox and coyote populations have increasingly encroached upon suburban and urban areas of many regions, and domestic dogs or cats may become infected when they eat infected wild rodents. Alveolar echinococcus has been reported in parts of Central Europe, much of Russia, Central Asian republics, Western China, the northwestern portions of Canada, and Western Alaska. Data on Echinococcus multilocularis from human cases are difficult to evaluate because of low human prevalence level of Echinococcus multilocularis infection, and the long asymptomatic period of alveolar echinococcus makes identification of infection trends in time and place difficult to assess. The annual incidence in endemic areas of Europe, shown on the picture, has increased from a mean of 0.10 per 100,000 during 1993 to 2000 to a mean of 0.26 per 100,000 during 2001 to 2005. There is evidence of parasites spreading from endemic to previously non-endemic areas in North America and North Island, Hokkaido, Japan, due principally to the movement of relocation of foxes. Hunters, trappers, and persons who work with fox fur are often exposed to alveolar hydatid disease. Hyperendemic foci have been described in some Eskimo villages of the North American tundra and in Western China, where local dogs regularly feed on infected commensal rodents. The infection of humans by the larvae Echinococcus multiculars is often the result of association with dogs that have eaten infected rodents. The liver is the primary location of the metacestode of Echinococcus multiculars in humans, shown on the left picture, as well as in natural intermediate hosts. Local extension of the lesion and metastasis to lungs and brain may follow. In chronic alveolar echinococcus infection, the lesion consists of a central necrotic cavity filled with a white amorphous material that is covered with a thin peripheral layer of dense fibrous tissue. Histology showing multiple variably sized vesicular spaces, as on the right, infiltrating into the liver parenchyma, giving rise to the description alveolar pattern. Vesicles have laminated membrane and periparasitic granuloma and chronic inflammation with eosinophils surrounding vesicles. Focal areas of calcification exist, as does extensive infiltration by proliferating vesicles. The initial symptoms of alveolar hydatid disease are usually vague. Mild upper quadrant and epigastric pain with hepatomegaly may progress to obstructive jaundice. Patients eventually succumb to hepatic failure, invasion of contiguous structures, or less frequently metastasis to the brain. The mortality in progressive clinically manifest cases may be 50 to 75%. However, instances of spontaneous death of the cyst during its early stage of development have been reported in people with asymptomatic infection. Alveolar echinococcus typically becomes symptomatic in persons of advanced stage. It closely mimics hepatic carcinoma or cirrhosis. Plain radiographs show hepatomegaly and characteristic scattered areas of radiolucency outlined by calcific rings 2 to 4 mm in diameter. The usual computed tomographic image of alveolar echinococcus infection, shown on the picture, is that of indistinct solid tumors with central necrotic areas and perinecrotic plaque-like calcifications. Results of serologic tests are usually positive at high titers. Purified Echinococcus multilocularis antigens are highly specific and permit serologic discrimination between infections with Echinococcus multilocularis and Echinococcus granulosus. Needle biopsy of the liver can confirm the diagnosis if larval elements are demonstrated. Exploratory laparotomy is often performed for diagnosis as well as determination of the size and extent of invasion. Actinomycosis is a chronic suppurative granulomatous inflammation caused by Actinomyces israeli, which is a gram-positive organism that is a normal commensal in humans. Actinomyces is a filamentous gram-positive bacteria of genus Actinobacteria. Actinomyces species are facultatively anaerobic, except Actinomyces meyeri and Actinomyces israeli, which are obligate anaerobes, and they may form endospores, while individual bacteria are rod-shaped hyphae. Actinomyces reifungus, from Greek, so this is the translation from the Greek word. Certain species are commensal in the skin flora, oral flora, gut flora, and vaginal flora of humans. They are also known for causing diseases in humans, usually when they get an opportunity to gain access to the body's interior through wounds. As with other opportunistic infections, people with immunodeficiency are at higher risk. In their branching filament formation, they bear similarities to nocardia. Actinomyces species are fastidious and not easy to culture. Actinobacteria presents in the gums, and the most common cause of infection is dental procedures and oral abscesses. Many Actinomyces species are opportunistic pathogens of humans, particularly in the oral cavity. More than 30 species of Actinomyces have been described. Actinomyces israeli is the most prevalent species isolated in human infections and is found in most clinical forms of actinomycosis. Growth of actinomyces is slow. It appears within at least 5 days and may take up to 15 to 20 days. Therefore, incubation of at least 10 days is required before conclusion of a negative culture. Most actinomyces species are facultative anaerobes, so cultures must be incubated in an anaerobic atmosphere. Actinomyces can affect people of all ages, but the majority of cases are reported in young to middle-aged adults from 20 to 50 years of age. No racial predilection exists for unknown reasons. Men are affected more commonly than women, with the exception of pelvic actinomycosis. The reported male to female ratio is 3:1. Human actinomycosis was first described in the medical literature in 1857, although similar disease in cattle has been described in 1826. Prov first reported the yellow granules in jaw masses of cattle in 1877. In 1878, Ariel described the first human case. In 1879, Hartz first observed the microscopic appearance of granules of actinomyces infection. Actinomyces are prominent along normal flora of the oral cavity, but less prominent in the lower gastrointestinal tract and female genital tract. As these microorganisms are not virulent, they require a break in the integrity of the mucous membranes and presence of devitalized tissue to invade deeper body structures and cause human illness. Furthermore, actinomycosis is generally a polymicrobial infection with isolates numbering as many as 5 to 10 bacterial species. Establishment of human infection may require the presence of such companion bacteria which participate in the production of infection by elaborating a toxin or enzyme or by inhibiting host defenses. They may also be responsible for the early manifestation of the infection and for the treatment failures. Once the infection is established, the host produces an intense inflammatory response and fibrosis may develop subsequently. Infection typically spreads contagiously, frequently ignoring tissue planes and invading surrounding tissues or organs. Ultimately, the infection produces draining sinus tracts. Hematologous dissemination to distant organs may occur in any stage of infection, whereas lymphatic dissemination is unusual. The inflammatory reaction in actinomycosis is suppurative, with formation of abscesses that contain one or more granules, 30 to 3,000 micrometer in diameter, that are bordered by eosinophilic club-like splendor herpy material. Once actinomyces species have invaded the tissues, they develop a chronic granulomatous inflammation characterized by the formation of tiny clumps called sulfur granules because of their yellow color, as shown on the picture. These formations, 0.1 to 1 millimeter in diameter, composed of internal tangle of filaments about 1 micrometer in diameter and a rosette of peripheral clubs, are stabilized by a protein polysaccharide complex, which is supposed to provide a resistant mechanism to host defenses by inhibiting phagocytosis. Histopathology examination discloses 1 to 3 sulfur granules in about 75% of cases, described as basophilic masses with eosinophilic terminal clubs on staining with hematoxylin and eosine, as shown on the picture on the left. Typical microscopic findings include necrosis and yellowish sulfur granules and filamentous gram-positive fungal-like pathogens. Yellowish sulfur granules are constituted by a conglomeration of bacteria trapped in biofilm. Histologically, chronic granulomas with fibrous stroma and cyst-like spaces containing characteristic granules may be seen. Abscesses like granulomas seen under epidermis which rupture forming sinuses. Gamorrean methanamine silver staining is also useful for demonstrating the filaments, as shown by arrows on the picture on the right. It is the most frequent clinical form of actinomycosis. The cervicofacial actinomycosis, and lumpy jaw syndrome, which is associated with odontogenic infection, the most common clinical manifestation representing approximately 60% of all cases. The disease is often a sequel to dental caries, periodontal disease, or injury to the oral mucosa such as tooth extraction. Consequently, actinomycosis is mainly considered as an endogenous infection that is triggered by a mucosal lesion in patients with poor oral hygiene. This form of actinomycosis is in the initial stages characterized by soft tissue swelling of the perimandibular area. As the localized lesion enlarges, abscesses form, direct spread to the adjacent tissue occurs, along with the development of fistulas that discharge purulent material containing yellow granules. Cervicofacial actinomycosis involves mandible, chin, and submaxillary ramus and angle. On the left picture, a large osteolytic region shown by the arrows, with a floating tooth shown by the arrowhead in the right mandibular body crossing the midline. On the right picture is an actinomycotic granules shown by the arrowheads and presence of sequestra shown by the arrows. Respiratory tract actinomycosis includes pulmonary, bronchial, and laryngeal actinomycosis. Pulmonary actinomycosis is the first most common type of actinomycosis, after that occurring in cervicofacial and abdominopelvic locations. Thoracic actinomycosis accounts for 15 to 20% of cases, the peak incidence to be in the 4th and 5th decades of life. Males are more often affected than women, with a 3:1 ratio. Pulmonary actinomycosis results mainly from aspiration of oropharyngeal or gastrointestinal secretions. Consequently, individuals with poor oral hygiene, pre-existing dental disease, and alcoholism have an increased risk of developing pulmonary actinomycosis. Otherwise, patients with chronic lung disease are at increased risk. Human immune deficiency virus infection, steroid use, infliximab treatment, lung and renal transplantation, and acute leukemia during chemotherapy may have also be described as a risk factor. Pulmonary actinomycosis could be associated with extrapulmonary spread from the lungs to pleura, pericardium, and mediastinum, and chest wall with fistula formation of sinuses that discharge sulfur granules. Finally, hematogenous dissemination with pulmonary location has been observed in patients with disseminated actinomycosis. Although cervicofacial actinomycosis is the most frequent form of actinomycosis with bone involvement, actinomyces species could also be involved in extrafacial bone and joint infection. Various clinical forms of extrafacial bone and joint actinomycosis have been described. Hematogenous spread of localized actinomycosis, contagious spread of pulmonary actinomycosis to the spine, polymicrobial bone and joint infection following bone explosion, especially in patients with paraplegia and osteomyelitis of the ischial tuberosity. Triton Ferry and Coffers reported a case of contagious spread to the spine with thoracic spondylitis of the T3 vertebral body. On the left picture, you see a thoracic spondylitis of the T3 vertebral body associated with anterior paravertebral abscess. On the right picture is a posterior epidural and infection of L2 and L4 vertebral bodies, shown by the arrows. Most patients with extrafacial bone and joint actinomycosis have insidious onset of the disease, and signs and symptoms are usually similar to those of chronic bone and joint infection and develop symptoms many months after the suspected bacteremia. Genitourinary tract actinomycosis is the second most frequent clinical form of actinomycosis. The main clinical feature of genitourinary tract actinomycosis is pelvic actinomycosis in women using an intrauterine device. However, other clinical presentations have been described, such as primary bladder actinomycosis and testicular actinomycosis. Colonization of the female genital tract by actinomyces species is greatly promoted by the use of an intrauterine device. The most common change associated with intrauterine device is focal or extensive chronic endometritis, shown on the picture, which may be accompanied by necrosis and squamous metaplasia. The symptoms of patients with pelvic intrauterine device-associated actinomycosis may mimic the symptoms of gynecological malignant tumors or uterine myoma or adenomyosis by presenting as genital mass without filler. Symptoms could be low abdominal pain, constipation, or a vaginal discharge. The duration of symptoms is usually around 2 months. A tuber-ovarian abscess strongly suggests pelvic actinomycosis, and similar features may also suggest malignant tumors. Mixed adenopathy is associated in 50% of cases. The pathogenesis of primary bladder actinomycosis is unclear, but could be due to the cryptic location and usually mimics bladder carcinoma. The lesion may invade adjacent organs such as uterus and sigmoid colon. On the picture, you see a computed tomography image obtained at a lower level that shows diffuse enlargement of uterus, signified by letter U, with small abscesses shown by white arrows. The perirectal soft tissue infiltration shown by the black arrows, and the intrauterine device shown by the arrowhead. Primary bladder actinomycosis can mimic bladder carcinoma as it is associated with microscopic hematuria and thickening of the bladder wall. The diagnosis of primary bladder actinomycosis is of crucial importance by guided biopsy, as it may avoid large surgical resection by suspected carcinoma. Actinomyces species as saprophytic organisms of the mouth and digestive tract. Digestive tract actinomycosis-associated actinomycosis infection in other locations may also mimic malignancy. Esophageal actinomycosis is infrequent. On the left picture, you see a computed tomography of the chest that demonstrates diffuse esophageal wall thickening, most notable in the subcarinal region shown by the arrows. On the right picture is an esophageal squamous epithelium with hyperparakeratosis shown by the stem and hemorrhage shown by the black arrows, secondary to actinomyces presenting as sulfur granules shown by the yellow arrow. Patients with esophageal actinomycosis are usually immunosuppressed by malignancy, HIV, or solid transplant. Most patients present with ulcerations and a few have perforation. Appendix, cecum, and column are the most common abdominal sites of actinomycosis, which can occur several years after gastrointestinal mucosal disruption, and for which previous surgery, such as for appendicitis or colonic diverticulitis with perforation, are predisposing factors. Signs and symptoms vary with the location of involvement. Patients with ulcerative involvement of esophageal have dysphagia. Patients with appendix, cecum, and colon involvement have abdominal pain with palpable mass, and patients with liver and biliary tract actinomycosis have right upper quadrant pain and icterus. Actinomycosis species are mainly involved in brain abscess. On the left picture, you can see the arrow, and it is signified by the arrow. On the right picture, suppurative granuloma consisting of central actinomycotic colony, shown by the star, is surrounded by neutrophils, shown by the black arrow, epithelioid histiocytes, and Langerhans giant cell, shown by the red star. red arrow, meningitis, meningoencephalitis, epidural abscess, and subdural empyema. The central nervous system involvement occurs hematogenously from the lung or contagiously from the cervicofacial actinomycosis or following a penetrating head injury. Central nervous system actinomycosis usually polymicrobial. Skin disruption may facilitate invasion of actinomyces species. Most patients may present with an abscess or cold mass of nodular lesions with fistulas, as on the left picture, that need to be differentiated from chronic inflammatory skin disease, cutaneous mycobacterial infection, and sporotrichosis. On the right picture, you see a skin biopsy. The deep dermis shows granuloma with sulfur granule of actinomycosis surrounded by acute inflammatory cells infiltrating deeply into muscular layer. Clinical actinomycosis can present as tumors mass and may be misdiagnosed as malignancy, especially in cases of actinomycosis oral cavity. Similar cases are reported in literature in which actinomycosis mimic not only primary malignancy but sometimes even metastasis. In breast, actinomycosis can cause necrotizing granulomatous masses and multiple sinus tracts. There are several complications, including osteomyelitis of the mandible, ribs, and vertebra, diseases of the central nervous system, including brain abscess, chronic meningitis, actinomycosis, cranial epidural infection, hepatic actinomycosis, renal actinomycosis, endocarditis, pericarditis, pneumonia, lung abscesses, bronchoectasis, empyema, psoriasis, etc. It also complicates other operations and situations like hip prosthesis infection, septic arthritis, endodontic infection, postoperative viscous endophthalmitis, etc. Actinomycosis is a chronic disease caused by actinomyces species. Physicians have to be aware of typical clinical presentation with such as cervicofacial actinomycosis following dental focus of infection, pelvic actinomycosis in women with IUD, and pulmonary actinomycosis in smokers with poor dental hygiene. They must also be aware that actinomycosis may mimic malignancy or sometimes associated with malignancy, so one should know the correct clinical presentations, morphological features, and histopathological findings to arrive at correct diagnosis and better management of patient. Bacterial cultures and histopathology are the cornerstone of diagnosis and require attention to prevent misdiagnosis. Typical microscopic findings include necrosis with yellowish sulfur granules and filamentous TIM-positive fungal-like pathogen. Specific preventive measures like reduction in alcohol abuse, dental hygiene may limit the occurrence of pulmonary, cervicofacial, and CNS actinomycosis. IUDs should be changed every 5 years in women to limit the occurrence of pelvic actinomycosis.